Hi, guys. Welcome back to another Mosaic Society podcast. I'm Shreya.
I'm T. Marie.
I'm Rosemary.
Today, we're going to be talking about healthcare models and price transparency. So, to begin with, what do we think is price transparency?
To my understanding, which isn't much, I believe health transparency is within the healthcare, like having a understanding of the payment that is required for certain services that you get or medication that you need when you're being treated.
Yeah, that's what I thought it was as well. Rose, do you have any other?
Um, I assume that it's the transparent cost of like the medicine or the like whether it's medicine or like x-rays, CTs, whatever, being transparent about how much it costs and where the cost is going. So, if you're like you need a CT for $50,000, is it like the CT costs $50,000 or am I paying a nurse $20,000 to roll me upstairs? Stuff like that.
All right, fair. Yes. So, this is what it is internationally defined as price transparency. Basically means that you give the patient a clear and upfront understanding of how much money they're paying or they might have to pay, where the money is going, and why is it costing so much, so that they don't get a surprise bill at the end that might land them in the hospital again. So basically, so that you understand what you're signing up for and that you don't get any, wow, okay, $50,000 for what? Five stitches? Okay. So that's exactly what price transparency is. Now, why is this so elusive? Because it should be straightforward. To understand that, and basically to guide the conversation a little bit, I thought it might be easier if we begin with basically understanding the different types of healthcare systems in the world. And most of the countries fall under these four types of healthcare models or systems. Forget about the name. The first one is where the government and the people through taxation pay for healthcare and everybody gets access to it. Everybody in the country gets access to it. That's the first kind of model. This is what applies in the United Kingdom, where they have the NHS. It's called the beverage model. And I've written mode there. It's model. Okay. The
Mm-hmm.
next one is called the Bismarck model. I'm not sure if I'm pronouncing it right, but I think it's German, where it's basically private insurance, where companies and the employees contribute to insurance, healthcare insurance. Both pay a certain share, like 10%, 15%, and it goes to a fund, a public fund, which then gives healthcare to these people who are insured. While it is private, because only those in working in companies that can have access or do contribute to these public funds get access. It works in a way where these private contributions become a public fund, and the government also contributes a bit. So it's like, if you the three of us are in a company, one of us is the owner of the company, the other two are employees, all contribute individually for ourselves. Like the employee would contribute around 10%, the employer would contribute around 10% to 15%, and that is put aside as healthcare premiums. And then you get access to healthcare. That's the second model. It does not provide universal coverage, so a lot of people are left out of that system, but it mostly works for countries like, and this is applicable in countries like Germany. The next one is the NHI model, where the government is the single payer. The government pays for all healthcare expenses in that particular country. And that way, everybody in that country gets healthcare. It basically tries to combine the public model in the UK, where the government and taxation provides for healthcare, and the private model where people, employees, workers, citizens are paying through their employment towards healthcare. They try to combine both of it and create a state-operated insurance scheme. So this is the third model. And finally, the most simplest model: you have money, you get healthcare. You don't have money, you don't get healthcare. It's called the out of pocket model. This is what applies in most developed countries. Hundreds of millions of people survive based on this model. Are you guys with me?
Um, so then, so what's the key difference between the last two?
The last one, you pay for it. If you're sick, you go to the hospital and you pay for it. The second last one, the state takes care of it. The government pays for it. Every
But
citizen pays.
still, not everyone has coverage.
Under the third model, almost everyone has coverage because it's basically every citizen is covered because every citizen pays the government a part of their income or part of basically a fee as part of health insurance. So the government takes care of it. Every citizen comes under the net. And they also have really strong social security safety nets. So people fall out. That is, they're not employed, they're not able to get private insurance. State takes care of it.
Hmm.
Okay.
I think I
Yeah.
get them all.
All right. This is what applies everywhere else in the world. Now comes the peculiar case of the United States, where you have a mixed system. You have a little bit of Medicaid, you have a little bit of Medicare, and then you have a whole lot of private insurance. There is no universal coverage. While there is some public financing for elderly people over the age of 65 and low income families, it's mostly minimum, and most people, around 50% of the people, end up going for private insurance. And around 10%, I think, are uninsured. So they do out of pocket. So you have to pay for all of it. You don't get any insurance. You don't get anybody who comes and takes care of it for you. Okay, where are we? Are we all on the same page?
Mm-hmm. Yeah, I'm here. I'm with you.
Okay. All right. So both the state government, the federal government, and the taxpayers do contribute to the system. And this particular graph, you guys can look at it whenever you want to. Basically, it looks at how all the money is being pumped into the system and how insurance works in that way. How the government publicly financed insurance works and how private insurance works. It's complicated, but it basically says how private households pay for private insurance, how the government pays for government employees to a certain extent, how they give extra insurance to private companies sometimes for certain classes of employees, and how those who do not fall under private insurance get public insurance through taxation and government support, or they used to at least. I don't know what's going on right now.
No one does.
Because I think a certain level of it has been cut. So, in a situation where you have private companies, regulators, um, regular citizens, or anybody else living within the country accessing healthcare, hospitals, pharmaceutical companies, and I'm forgetting a couple of other people. Who do you think, in your opinion, who do you think are the main stakeholders? Or at least who's the most powerful?
So you're saying, to reiterate,
Hmm.
there's state with state insurance, federal insurance, private insurance. Government paying jobs usually cover you to an extent with their insurance. Those with in a private household who have access to it are able to get the private health insurance. That's the
Yes,
general gist.
yes, because it's cut from their paycheck.
Yeah.
Hmm.
Um and then I guess I'm with you, but in my head, I keep thinking, which is why I also asked the question in the last slide. There's a lot of people who don't necessarily have jobs who cover insurance or who are working part time and aren't eligible for insurance, or it's not really insurance. It's like they'll give them a little bit of like, here's $2,000 a year that you can use towards your wellness. So I guess like, I don't know what the percentage of people who are fully insured would be, but who benefits the most would be the people who can afford the private health care. And then somehow, because everyone's paycheck, you do get taxes taken out of it, that government is benefiting. Because of millions of people upon millions, even part time, if you're having taxes taken out, then I can only imagine the sum of that each year. And it should be able to cover everyone. I think. Logically speaking, that's what my brain thinks, but I don't know if that's the case. So, who benefits the most would probably be the government and then the private health insurance people.
Okay. I think that's where the next bit comes in, where you look at the healthcare system as something that is providing an essential service and therefore is non-profit, or it's looked at as a market and therefore for profit. When it's the
But
former,
go ahead. Sorry.
when it's the former, um, insurance companies not insurance companies, those institutions that manage financing of healthcare and pricing of healthcare and provision of healthcare are unable to profit from it, or at least those who are holding all that public funds are unable to profit from it, because there are really strict central regulation rules that would control it. On the other hand, the US does look at it like a market, which is why all of these issues come up largely. Because if you look at it, it's like people are expected to select off a menu. Patients are expected to select off a menu where you basically said, okay, in this particular hospital, I'm supposed to be paying this much for, I'd have to pay this much for, let's say, getting an x ray and getting a surgery based on that. And in this hospital, I'd be paying this much. My insurance company covers all of this. My insurance company also caps me at, let's say, $30,000. How exactly do I maneuver that? It's all on the consumer. Basically, in the effort of providing more options for better care, it becomes unaffordable options for mediocre care, and in some cases it becomes unaffordable options for those who cannot get basic care. That's where the gap is, which is why the US system seems a lot more difficult to understand or to get behind. I don't think the government is pocketing money that goes towards Medicaid or Medicare. That's a different discussion altogether. Um, do you think that's happening though?
Me?
Mm.
I think that it's not necessarily, legally speaking, it wouldn't be considered pocketing. But I
Mm.
do think there's always loopholes within the government where money can go based
Mm-hmm.
off of the laws and policies that are in place. So I don't think it's like a Ponzi scheme, right? Like I don't think that's what's going on. But I think if you look at the US government's budgets and state budgets, you can see what they value more over others. So I do think budget wise, they can take a lot more money and put it towards Medicaid, towards, I guess, let's say like the top 20 diseases in the US that people need help with, and put more money towards that. But they value other things. So that money might go elsewhere, or the way they set it up might help them in the long run. I obviously don't have proof. You're teaching me about the healthcare system a little bit more now, but historically speaking, if you look at someone's money, if you look at the budget, you can see what they value. And the value isn't in the healthcare system. It hasn't been.
Yeah, I can agree with that. If you're talking about the same thing, India's annual budget, every year they publish an annual budget, right? So basically they talk about how much money the government has and how much they're going to be utilizing for different sectors: the agricultural sector, military, education, health, infrastructure, and etc., etc. And health always ends up getting the least. That's always been the case, which is why a lot of countries that struggle with severe health issues rely on international donors, international organizations, and funds to be able to improve their health outcomes. So that, I don't think that's a sign of embezzlement. You're right to say that it does indicate the, how do I put it? It does indicate the importance that the government is giving to healthcare, or to affordable healthcare to their citizens and to their people, or the people living in their country. To that, I agree.
What I've been thinking about, I'm also trying to base it a little bit off of the little bit that I've seen. I haven't experienced the healthcare system personally, like my family has, but I more recently have, and even still, I'm just seeing things little by little. But when I think about like the stakeholders and like who might benefit the most from my experience, I'm thinking the I don't even not the pharmaceutical companies, but like the companies that decide on like the pricing of things. And the reason why I'm saying that is because I remember when I switched between two different insurances based off of like my parents' jobs. I was on one parent's and then I switched. And I remember, I don't mind saying the insurance company, I was on Aetna, and it was around 2 years ago I started needing to get blood work done at like LabCorp. And I would go and I could go get my blood drawn, no copay, I could be out. And then after I switched, I went in there and they're like, "Oh yeah, you owe da 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 da." Now in my head I was like, "Money." I was like, okay, yeah, here's my card and everything. But I just thought that was really interesting that based off of the insurance that you have, it really impacts like things like the copay, just like little prices and things that add up. Because I've had to have my blood drawn like maybe four-ish times over the past like 2 years. And so if I had to pay every single time, like that adds up and that might be a deciding factor on whether people take their doctor's advice to get blood drawn or just routine things such as that. So it makes me think that the people who really have the power are the ones who are pricing certain things. I don't know exactly what that institution is. Maybe you guys have like said it or something, but yeah, that's how I'm thinking.
I'll say I do think that those companies have more, I don't know if, well, part of it is power, but more benefits than the government for sure. I think the government can help more with regulations and policies if they're not going to help with their own healthcare. Like, at least you could regulate these. But I was talking to someone who works in Medicaid in Louisiana, and she was saying how she's one of the six consulting organizations in Louisiana that help with Medicaid. So there's six of them that help people, low income people with Medicaid, and how basically depending on which one you get, which of the six you get, you have more benefits with Medicaid than without. Which I thought was weird because I was like, it's Medicaid. Like at the end of the day, it's a healthcare system for low income families. And so it should be a general understanding of what's covered and what's not. But she was saying how her company, they'll offer like wellness stuff, and they'll have like they'll send a crib to the mothers when they have kids, because in Louisiana apparently it was like a big deal. There was no cribs for newborns and they were dying because of it. So her specific consulting firm, I don't know if they're called consulting, but outreach, I guess, would send cribs, but the rest of them wouldn't offer that. So I do think these private companies who are in charge of the pricing and who gets what and saying approved or rejected do have more power and benefits.
Yeah. No, you guys are right. So if we look at how pricing is set in the United States versus other countries, in the UK, which follows the beverage, I'm not sure if I'm saying it right, but I think it's the NHS. The government sets the price, and the NHS sets the price. So there's you just go you patients and people who are going to the hospital are less worried about the pricing as such, because there is a standardization, the centralized control over it, except in private institutions, which operates on a different level or on a different scheme altogether. In the US, the government does not exercise control over pricing as such. Pricing, except for Medicare and Medicaid, they do have regulations for Medicare and Medicaid, but it's not exactly, there are different classes to it, the different types to it. So that's another complex issue altogether. Prices are usually set by negotiations or through negotiations between hospitals and insurance companies. And pharmaceutical companies also end up playing a role in this. So if one, for example, you shifted your insurance company, didn't you? You shifted your insurance provider.
Mm-hmm.
Your initial insurance provider probably had a different arrangement than the next one. So prices differ based on that, which is why there's a huge confusion, because why is it that something that I um, got from my previous insurance provider at $100 is costing me 150 or $200 or more with this new insurance provider? It's the same thing. It's the same nurse or the same assistant poking my arm and drawing the same blood that they would a month ago. So that's where the price difference comes in, which is why there's a lot of confusion, which is why it makes it so much more complex, because it's like 100 agreements with the same institution or with a group of institutions, which forms in network, out network. And when it becomes so complex, how exactly is the government supposed to control that? Because it's a monster, right? How exactly are you supposed to control something like that? How exactly do you enforce rules which would help patients get affordable care? And like Rose said earlier, people who are left uninsured are in serious trouble in the United States, because it is a very complex and expensive system. Don't get me
Mm-hmm.
wrong, there are positives to it because a lot of people who can afford it, travel to the United States for specialized care. Like, I know a lot of people who would travel to New York to get cancer treatment because it was so good, because they have that kind of research capability and progressive, not progressive, or advanced scientific medical expertise that other countries may not have. But it comes with a price, which not everybody can afford. So I think that's where the issue is. Yeah.
And that makes a lot of sense what you said about the different contracts for different insurances, because the parents the parents insurance I was originally on did work for a pharmaceutical company, and then the
Mhm.
other one worked for a tech company. So I think it was just different what they were covering. So that makes a lot of sense.
And there was also this entire thing before Trump came in, that they were trying to negotiate ceiling prices for certain essential drugs. For example, for insulin, I think there is a ceiling price for insulin and it cannot go above $25 or something along those lines. I think there was also some for other life-saving drugs, which basically meant that if you don't have this drug and it's a chronic disease, if you don't have this drug, you will die.
Mm-hmm.
So I think there were rules or regulations that cover drug prices, certain drugs that are in place right now. But even then, it is largely driven by market forces. Another thing is the entire thing about generic medicine and patented medicine.
Can you
Do you
explain
guys
that?
know
I'm
the
sorry.
difference?
No,
Sorry,
sorry. Can
You
you
wait.
explain?
You said generic medicine and what medicine?
patented medicine, patented like name brand medicine.
Okay.
Oh, okay.
Oh, that's like Zyrtec versus Walgreens allergy pills.
Yes, at the basic level,
Simplified.
it's something like
Yeah.
that.
I
Yeah, the
thought of a
basic
food
level
example.
is
That's
like
funny.
so. Some doctors, at least this issue is where it's very common in India. When you go to like big hospitals, they would prescribe you medicines that are super expensive. But if you go to a government hospital, if you ever do go to a government hospital or a small clinic, you'll get similar medicines acting on the same for the same diagnosis, performing the same function at a much lower price. In the sense that you can get metformin for thousands of rupees, or you can get it for like 50 rupees or 100 rupees or lesser even. And that's all because of the company and whether it is generic or if it's like branded in some way. And it becomes like a huge thing where you're basically inflating the price of treatment and healthcare by doing something as simple as saying that, oh, okay, this particular pharmaceutical rep came and told me that I should be doing this, or I like this particular drug. Whatever reasons the doctor decides to do so, it creates an alternate system in some way where doctors and healthcare providers are influenced by these drug companies. Hospitals are influenced by drug companies, and it creates this alternate system. I mean, it's exposed now and they've changed their rules, but this was a huge thing. Like, I think around 15 years ago, it was like a big thing in India where people were like, is this the most cost effective medicine that I can take? Because you're talking about medicine that you need to take for a lifetime,
Hmm.
unless you undergo a really drastic healthcare or body lifestyle change, which means that you don't need it anymore, which is rare. So yeah. So in the US, the hospitals come up with a list of prices for their medicines and for their services. Then they negotiate these prices with their insurance companies, with the different insurance companies. Some of them offer discounts, some of them don't. And then comes the final price that the customer or the patient then accesses or has to pay based on these agreements that they reach. Similarly, Medicare and Medicaid, this federal government has fixed reimbursements and rates for most services that can be provided through Medicare for their patients who basically access healthcare through Medicare. And states run Medicaid. Yeah. So apart from these two services, private insurance is like it's free game. So that's where the issues come up in the United States. And those who are not insured, basically they can go. I don't know the polite terms for it, but it's quit game for them.
Mm.
Yeah. So that's the US healthcare system, which is really interesting because something very significant happened a couple of months ago. Yeah, around Yeah, earlier this year, I think it was, or maybe late last year. Luigi was his name. Luigi.
Oh,
Luigi. Luigi.
Mangione,
Yes,
I
him.
think.
Yeah. So Luigi goes up. So who, based on information that came out later, seems to be someone who was denied health insurance or denied a particular surgery that would have that would have prevented him from feeling lifelong pain, chronic pain. I guess that, along with general frustration with the insurance, the healthcare system in the United States, went up to a CEO, pharmaceutical company CEO, and shot him. So a lot of people say this has to do with the healthcare system. What do you guys think?
Honest to God, after I looked into like Luigi's case, and I'm gonna say allegedly because the trial he hasn't been convicted, so legally speaking, allegedly.
Hmm.
Um,
Right, I'm sorry. Yes,
I
allegedly shot man. And convicted.
this is what keeps going through my mind when I think about this case and this situation. You shouldn't take anyone's life. Like in my head, it's like we're all human beings. We're all on the same levels, right? We're all on the same playing field. No one's God. Like you can't play God and just take someone's life. Like that's wrong. But then where's the line between taking someone's life with your hands and then taking someone's life with paper, right? Like actively denying people life-saving medical coverage to have an increase in your pockets or in your company, to keep the money flowing for you, even though it costs someone else their life, that's murder too. It's just through paper. So, like, where's the lines? Where are the
and it's considered
regulations?
legal.
And it's considered legal, right? So, if I
Mm-hmm.
like shoot someone or stab someone or strangle whatever, like, that's an immediate, like, murder, you're arrested. But if I deny someone healthcare, life saving healthcare that they have been begging for and asking for years, that'll help them live a better life, I'm killing them. Like that's a choice. I'm making the choice to allow them to suffer and then eventually die. Um so I always think about that. Like that's what's going on in my head cuz I'm like if he's found guilty for this and they have the evidence to prove it that it was him or if he confesses, I don't know. But if that happens, okay, but then how do we manage the healthcare system that's killing millions of people a year? Like it just doesn't. There's so many people, like even with insulin, like I remember that was huge. Like people would go to Canada to get their insulin and then come back. Like that shouldn't be a thing. You're literally killing people, killing kids just because you want more money in your pockets or because it's the system that you were raised in, right? Maybe you went to school for this and this is how you played the game to be at the top. Whatever it is. Like you're still killing people. It's not really fair or justified. So I don't know. I'm just like, if you're gonna say he's guilty, then you should probably look at the other side and not be hypocritical and be like, oh, y'all are guilty too.
Yeah, I agree. Similar to Rose, wrong is wrong. You can't play God and everything, but I understand the anger of the other side. Um, and I'm even thinking like with someone I know, the price of they're on blood thinners and obviously they have to be on blood thinners for life, but the price of I believe it's Eliquis, I think that's the drug, it took a drastic leap in pricing and it's like, well, that's something that they need for life and it just seems unfair that certain institutions have such grasp over it and it's something that is uncontrollable for people and you can see where it's like you can kind of feel hopeless and despair and like the big institutions don't care about you and so it's I understand again wrong is wrong but I can understand it from that side and I also with the alleged Luigi case and everything even though it is very much so rooted in healthcare, I've always thought about it from like another big issue, like gun control, and how people seem to care more when a CEO was shot, but not when kids in schools have been killed for it's over a decade now. Is it almost like 2 decades now since what is it, Columbine?
Columbine was
Columbine.
1999, I think, or 98.
Yeah, so it's been over what like 2 decades now, and nobody really seems to care. But when it was a wealthy CEO, there seemed to be more conversation. But so I just think it's like a anger, and I can understand it, and I think it's a real indicator where it's like people are feeling oppressed to this degree through healthcare. Obviously, this is an indicator that serious change needs to happen because even though Luigi shouldn't have done what he allegedly did, he shouldn't have also gotten that news that his life-saving care wasn't going to be um not awarded to him but given to him.
Yeah. No, that I agree with you guys. Which leads me to the next bit that I'm thinking about. How would you, as people accessing this healthcare system, you both need to live through this healthcare system. So from that point of view, from as stakeholders, what would you guys think? How would this system best serve people? What do you think needs to change? And it doesn't have to be like a super well informed thing. Basically, as a person who accesses healthcare and who needs to live the rest of their lives in that system, what do you think needs to change? And basically, based on your lived experiences, what you've heard, what you've seen.
It's interesting because I do think, just from like things, I haven't done a lot of like research on this, but I've even seen like people in Canada who have universal healthcare. They talk about yeah, we have universal healthcare, but it's not like the best. And then they do compare it to like America, where it's like at least we have something, but you guys do have more specialized things. So I do see the benefits, as you said, of like the private healthcare, and like we have access to certain research and everything, cancer treatment and stuff. But I do think there shouldn't be a thing where there are some people who don't have access to it. I think there should be coverage for everyone, because I think that is something that is, if we're in the United States, we like to talk about how great we are and how we're this and that, but you can't even give health care to all of your citizens. I think that's a little crazy. And it begs the question, great for who? So I don't know how. The how, I have no idea, but I think ideally everyone will have healthcare, and sure, keep the private stuff, keep all the extra, fine, if you can afford it in some way. But everyone should have coverage. That's my thing.
So you would prioritize universal healthcare coverage then?
Yes.
Okay, all right. That's what a lot of people say. That's actually one of the goals. In fact, a lot of countries consider healthcare or access to healthcare to be a human right, a basic human right.
I
And if you
agree.
need access, it has to be affordable as well. There's no point of saying, oh, there's a hospital right there, but what if you can't even get a drip in that hospital? You'll
Mm-hmm.
bankrupt yourself getting a drip in that hospital. So accessibility, affordability comes together. One of the cornerstones of a healthcare system. Rose, what do you think? What would you want to change?
Um, I don't think that America's healthcare system can change until private insurance and private like pharmaceutical companies change and there's more regulations on them, because I do think it starts there. When you start talking about like the pricing of a drug or generic drugs or name brand drugs versus generic drugs, like, and then negotiating with hospitals what would be covered, it really does. The pharmaceutical companies and these medical companies, they have a lot of power for people who aren't necessarily equipped with understanding the medical field. Like, I would understand, it's wrong regardless, but I would understand if it was like, oh, this doctor was a surgeon for 20 years, this doctor was an internist for 15 years, and they're running the pharmaceutical companies because they understand face to face what it's like with the patient. And they're like, okay, this is what they should be cost. This is what's important. But it just seems like there's a lot of business people who get into insurance and privatized insurance and the um, pharmaceutical companies, like the drug companies. I'm thinking of the one for depression. Um, it starts with a P, I think. It was like a big deal in the 2010s. People were switching to the name brand. I can't remember, but anyway, those type of companies, the name brand ones, they have too much power for people who don't sit in the offices with these crying mothers and then the crying children. And it's like, you don't understand what they're going through. You're just here trying to make more money. You're looking at it from a business perspective. So until those companies are managed and regulated and they change the way that their system is built, it's not going to change in America. And obviously, they're not going to change it because they're making good money. So the government has to step in and do it. But then it begs the question, how is the government benefiting from it? Because they are in some ways. If this system has been happening for this long, the government is benefiting from privatized insurance. How, I'm not sure, but they are. And they won't change it because they don't value healthcare based off of their budget. So I don't think it matters how it changes if they don't change those companies.
No, I understand that. I think you're addressing multiple points when you say that. One, the fundamental principles based on which the healthcare system was developed, which was very capitalistic and market driven. And I'm not using capitalism as a word as an accusation. It is a system that drove the development of today's healthcare system in most developed countries or many developed countries. So that's not the problem. So that's one thing. And then the next is how fragmented healthcare services are in the United States, or how fragmented the financing of healthcare is in the United States. You have pharmaceutical companies who then have to negotiate with insurance companies who negotiate with hospitals. And it's not that there's a universal rule that applies to all of them. So there is administrative fragmentation in this healthcare system. So there are multiple levels to it. And there are also basic principles like how socialism is tied to universal healthcare, and how socialism is tied to affording healthcare to those who are unable to contribute to universal healthcare. So, Canada citizens pay a part of their taxes to healthcare, a huge part of their taxes. I think around 50% of their annual income goes to taxes. A portion of that goes towards healthcare. And it's not without its flaws, like you said, right? Because who said that about Canada and yeah, Team T. I almost called you by your real name.
Mm-hmm.
I was like, I was like, anyway, yeah. So in Canada there are wait lines. In UK there are wait lines. People wait months to get surgeries, to get appointments, to get basic healthcare services. In the United States, that's not an issue because, I mean, there might be a wait time, but it's not weeks or months. Maybe weeks at most. But months is a lot. So imagine sitting with a debilitating injury that, meaning that you're not critical. You can live, you'll survive, but it's just that you need the surgery to be able to function, have full functionality of your limb, and you need to wait weeks, if not months. And this really weird thing. I've been following this TikTok couple, not TikTok, YouTube couple, super ashamed of it, but they're fun enough. They're based in the UK, okay? And they had a baby recently. The woman has not met her doctor once. She has midwife appointments. She has telecalls with her doctor, but she doesn't meet her doctor face to face. I don't think she had. In like a span of 9 months, she met them maybe once or twice. And otherwise, it's just midwife care that you get, and she needs like a C-section. So she basically goes and meets a midwife, and then she gets a call, and they say that, yeah, you need, I've seen your levels, you need to schedule. And then she doesn't have any connection with the surgeon who's performing the surgery. It's like the day off, they let you know which hospital you need to go to, and sometimes they'll shift the hospital because there's just too many patients. So yeah, so it's not personalized care. In the United States, you get personalized care, they just leave you with a huge bill after. It's not that it doesn't come with its negatives. Yeah. So I see multiple issues here. Wait, which leads me to my final question actually. If you had to shift healthcare systems, would you pick another one? Or would you stick with what you have in the United States?
I think it depends on what you're looking at. I think maternal care, some places outside the US have appeared to be more what's the right word? Safer? Just because I feel like, especially when you look at Black women in maternal care, they don't always get the best care. Black women don't always get the best care in America. So in that regard, I do look other places. But when I think about like the things that I might need healthcare for, like my health things, the system as it is, I guess America, but I also have not done my research really to see other countries and how it looks there. But yeah, so I'm not sure. But from the maternal aspect, like having a child, from what I've heard, I feel like the US is not the best. Like
Not the
even
best.
Serena Williams, almost, she had issues in her when she was giving birth to her first daughter, I believe. And it's like that's a wealthy Black woman, the GOAT of tennis, and she didn't even get the best care that she was owed. So it's like it's scary, you know?
Good point. I also think that's another thing that needs to be talked about because I feel like what's really bothers me in conversations like this is I'm sure it's a universal thing, it's not just America, but I only know America. We separate things a lot. Like this is the healthcare system, this is racial inequality, this is the I don't know, the job market system, but they're all interconnected. And I don't think there is enough overlap between them for us to fix what's wrong. Because, like, what you're talking about, Black women in healthcare, that's something that's been happening for centuries, right? Same with just like minorities as a whole. Like in the textbooks, having that Black people can handle pain better than white people, like that was in textbooks up until recently. Even now, like I know there's a couple people whose teachers said that when I was in college. So I think there needs to be more overlap into the different systems that are presented, because healthcare is influenced by racial inequality or racism, are also impacted by the economy. The economy impacts job markets, which is impacting education, which impacts like when you start talking about gender norms, like it's all interconnected. And so I feel like if there's a system where yeah, you have to separate it so people who are specialized go in their area, but there's always overlap and people are always talking about the connections within them, we would have a better system, not just healthcare, but universally speaking. So yeah, I think that's what we keep like let's just focus on this sometimes, like as a country, but it's all interconnected. And until we start making it more, we keep trying to simplify it to help ourselves understand it better, which I understand, but we have to make it more complex in order for us to see where are the holes and what's the problem.
Absolutely. And I looked up the specific because I wanted to get it right. Black women are 3 times more likely to die from pregnancy related
Yeah.
cause than white women.
I just
And that's
I
from the
cannot.
CDC.
No, you're right. No, there was this one article that I read about um, Black women having lower, ha contributing highly to maternal mortality rates in the United States in comparison to other communities. And this is mostly because of the healthcare that they're provided and how how they're able to interact, or how their interaction or communication is received by healthcare providers. And this particular article was emphasizing how having your support system, like how they have a guardian in South Korea, where they have the guardian with the patient, how they play such a huge role in ensuring that an advocate, basically having an advocate helps a lot. And in many cases, Black women in labor were saved from potential life-threatening consequences, or lapses, because of their guardian advocating for them.
Mm-hmm.
So, yeah, I did read that article. It was something that came up. Based on what Rose said, it takes me. I wasn't going to discuss this, but I thought it was really important. So, you see, this is basically a food system and how it interacts with different elements. You can see economic, biological, food, social, political, and then the health system, the tiny little orange thing in the corner. And everything interacts with each other. Nothing operates in isolation. But for governance, it's difficult if you have an agricultural minister in India, you have an education minister in India, you have the civil service or administrators. How exactly are they supposed to interact if each decision made by, let's say, the agricultural community can impact everybody else, or something that is done to prevent caste discrimination has an impact on health and food and social systems? So it's complex. Rose, you were saying something.
When I first looked at it, I was just looking at the farming first.
Yeah.
Like the fact that it goes all the way back to farming, how we, is it cultivate our food? I don't think that's the right word.
Okay, grow our food, I
Sounds right.
guess. Yeah.
Harvest? I don't know. How we get our food. Like it goes back all the way to that. And so like for example, if you see that most people in southern US, the Bible Belt of the US, are struggling a lot with digestion. You should, and you're like, oh, people are really struggling with their stomach. You should eat this more, eat this more. But why don't we just look at the farming? What are the farmers doing that they could be doing differently that could help us? Not to blame the farmers, but maybe there's the way their system is working is counteracting with the system of the healthcare or your biological system, which is counteracting with the healthcare system, you know? Like there's a lot of root causes for things that can be addressed and can be fixed if these systems work together. If you look at food deserts with the economy, if you look at education, sometimes it really is simply education, allowing people to access to understand how your body works and what you have access to. Some people aren't educated on the healthcare system. Like I'm assuming like we all had like our own version of healthcare system, like when you were, or healthcare or insurance, like when you were here, Shreya. We have a general understanding, but we still don't get it. I remember when I got my first full time job and they were talking to me about insurance, girl, use it was so complicated. I didn't understand it. And sometimes, and I ended up going to get, like, I needed to get my blood test for my allergies again because I do it every few years, and it was $500. And my insurance that I had at the time couldn't cover it because it was two insurances. So I had my primary insurance and my secondary insurance, and I had to share both of them with the person. And then the primary insurance would be like, no, talk to the secondary insurance. And I got lost. I can't even lie to you. That bill is still unpaid. It's sitting there. I'm not paying it. I don't understand because I'm told, yes, all this is covered. But then when it comes down to the system, it's messed up. So anyway, that was multiple different things, but they're all interconnected.
And I
Like,
think,
truly.
yeah, and I think to your point about you didn't really know until like you had a job and you're dealing with it. It's a shame that so many people don't understand it till they're forced to understand it and they don't go in with that knowledge. And it's kind of like you just have to mess around and find out, which shouldn't be the case. We spend so many years in mandatory schooling, things like how to pay taxes, healthcare, economics, like these things should be understood and taught
How
to
do you
us.
financially plan your life? None of that is taught in schools. I learned that last year. My uncle has prepared a presentation saying, like, you're dumb. You need to follow this presentation and save your money and do something with your life so that you can retire comfortably whenever you decide to retire. Do this, please.
But that's the thing. Like, it's all weaponized.
Yeah.
Like, I
Knowledge.
usually, it's weaponized. I usually
Mm-hmm.
look at like weaponized religion because that's where my interest lies, but education is weaponized as well. What they teach you and how they teach you and the access to the education that you have, it keeps you in this system of, it's kind of like when they talk about African Americans and like, I forgot what the documentary was, but it was a documentary talking about how African Americans, once they were quote unquote freed with the 13th Amendment, and they went in and then they had to start making their own systems of like money and like, how does this work? Like, how do I create generational wealth? But then at the same time, right after they were freed with the 13th Amendment, you had Jim Crow and you had segregation and you had a lack of access to the educational schools for these marginalized black communities. And then you have the civil rights movement and now everything's integrated, but you still have gerrymandering. I know that's like more political, but you also have it with like, what school are these kids going to? What neighborhood is designated to which schools? It's just weaponized, and it's been weaponized for centuries. And that's why it's like you have to talk about the education system when you bring up healthcare. You have to talk about the agricultural system when you bring up healthcare. You have to talk about all these different things because for centuries it's been weaponized to benefit white people. Facts. Like, that's it. It's been weaponized to benefit white people, and now that it's integrated, you can see a stark difference as to the care provided to marginalized communities, not just black people, but marginalized communities everywhere. So yeah, it needs to go back to, I don't like that we don't look at history enough, because if you just look at history, you see where the problem is. Fix
Yeah.
the problem.
Food deserts do go back to redlining. That's something that,
Redlining. There you go.
yeah, it does go back to that. You see that, look at New York. You find districts that were redlining in that particular, in those areas, they have peculiar food outlets there which are typical of, let's say, I wouldn't call it a food desert per se, but just unhealthy food options, lack of affordable healthy options. I mean, when I look at, personally, when I think of food and health, I think of food as medicine, because healthy eating can prevent a lot of chronic diseases, can help people avoid a lifetime of consequences. For example, stunting and wasting could prevent CVD, physiological issues later in life. Healthy eating can prevent diabetes. So, food and health do go hand in hand. And food deserts, or the way people cultivate food, has a role to play in it. There was this, I think I've mentioned it earlier in another podcast. There was this one community in somewhere in the African continent where they only grow plantain. Every inch of land, farmland in that particular village grows plantain. So they eat nothing but, that's their diet entirely. There is no variation whatsoever. They just make a porridge out of it or they roast it and that's all they eat. Obviously, while it does provide you with dense calories, it also has consequences because you're not eating enough of the right different food groups. So those kids have health issues because of that. People there have health issues because of that. So it combines a lot. And they're growing all of that because they need the money. If they give up an inch of that land for something else, they lose money. So it's tied with economics as well. So there's a lot to it.
It is sad though. Everything, like, I think it's sad to think that the government that is meant to support us and uplift us and help us is continuously putting us on the back burner.
Going back to that point, most healthcare experts, the healthcare, basically WHO says that around 15% of your annual budget, the country's annual budget, should go into healthcare or just providing health services. I don't know what percentage the United States is at, but if it hits 15, that's pretty good because there are various priorities that they need to focus on. And healthcare doesn't always reach very high up because most people are in crisis management mode and not prevention mode, where you wait until your crisis is upon you and then you're like, oh, what do we do now? And then you try to fix the issue. You don't think about preventing an issue or prevent or creating systems that might help you. COVID helped a little bit. People are more aware of the gaps in healthcare systems now, but that's dying down again because COVID seems like the past now,
Hmm.
like in 2025. But that's just generally how countries operate. I think India spent around 8%, 7% of their annual budget on healthcare. Completely inadequate, but I think most countries follow the same path. But there's also lobbying. Pharmaceutical companies lobby governments or presidential candidates, and that ties presidents once they're in office to their agenda, which is an issue. Also, if you look at the US healthcare system, it's so complex. Like, how do they even begin regulating it? I mean, it is a regulatory nightmare. I mean, to give them the benefit of doubt, it is really difficult to regulate something that is so complex, especially when the founding principles of that market was freedom and free market. Free market principles, innovation, primacy of innovation, rewarding innovation so that there's more scientific progress is the basis of it. How exactly are you supposed to regulate that without huge backlash from those in positions of power?
Like, side note, also, well, not side note, it's on side tangent. I do, I get to a degree giving benefit of the doubt. There's certain people I'm like, okay, I'll give you benefit of the doubt. But I think it was made complex on purpose. Like, it was a very intentional decision that was made to make this system so complex that only a few people understand it, so that only a few people have access to change it. Um, and so I feel like until they acknowledge that, until they fully acknowledge, oh yeah, we did kind of take advantage of this healthcare system because we knew you could understand it. Or, oh yeah, we made it complex intentionally. Or we made it complex knowing that it wasn't going to work. Then it won't really change. That's the only way to really start, because once you acknowledge that it's complex intentionally and why it's a problem, then you can create a solution. But if they start regulating it now based off of what people are like advocating for, but not necessarily the root cause, the problems are still going to come up. It might get a little bit better, but it's not going to solve the problem completely. So I think new politicians are going to have a lot of struggle because they have to better understand, like, oh, how do I go about this? Like, how is this created? I have to understand it better. But I think politicians who have been around for decades, who need to retire, they get it. Like, they understand how complex it is and they chose to be complicit in that system.
Yeah. I to the point that you said a few minutes ago about like how education is sometimes like weaponized. Going off of what you said, I really think when you see a lot of these recent events that are happening, I think there's a reason why there's been a lot of talks about what's in museums. There's been a lot of talk about education and history, and I think it's because they don't want certain information to be they don't want everyone to be informed, because then that calls for more questions and more about why are we doing things this way when historically X, Y, and Z has happened. And I just I don't know if y'all have seen the viral clip from Trump where he said smart people don't like me, but I think I don't know the context of the viral video, but I think it's true. I don't think he wants people informed about certain things because they want to be able to move the way they want to move. And when you have a fan base that is kind of blind following you, who's gonna really dispute anything you say?
There was a study. I saw this a few months ago, or maybe last year or something, probably during the election. But there's a study of which states have the number of Trump supporters in a certain state and the lack of education. And usually the states with the lack of education, like access to education or having a good education system overall, those are usually the states with the higher percentage of Trump supporters.
And it's really
I was
sad.
like,
it's really
very
sad.
He take advantage of that, or he took advantage of that. His people.
And the thing that got me was everyone in the room laughed. I said, "So what do you think you guys are?" If he laughed and said, "Smart people don't like me," but I digress.
Which reminds
I've never
me.
seen that.
No, sorry, that clip does sound funny. Sorry, I interrupted you, Rose. Go ahead.
No, I said I've never seen it. That clip.
Reminds me, Trump has imposed 100% tariff on the import of patented drugs into the country.
So that's the name brand ones.
No, it just means that any drug that has been patented, I don't understand the logic, but it just means that a huge proportion of drugs that come into that are imported by the United States now have 100% tariff on them unless the company manufactures in the United States.
Like, I, and the thing that gets me is everyone has a specialty. Like, I see these problems, I see what's wrong, this, that, and the third. But my specialty lies in religious and spiritual understanding and intersectionality and identity based work, right? I want to fix this, but it's not my specialty. It's not what I've studied, it's not my interest, and I can only do so much from my point of view. And then you have all these other people whose specialty does lie in this and they're trying and they're working towards it, but it's blocked all the time. They don't necessarily have the numbers or the finances or whatever it is that the resources to push it and change it. It truly irritates me. Like it's such an intentional no, you can't do it, to the point where it's like you want the nation to crash and burn before changes happen. Like that's basically what it sounds like the government is saying. Some people in the government, most people in the government, politicians.
I don't know. I don't understand the logic behind this because in the end of the day, this just makes healthcare super unaffordable for American
Mm-hmm.
households that already spend around 10% of their income on medicines. Who does that? So anyway, just a side note. Anyway, so so that's it. I don't have any other questions for us except for the segment. Do we have any other final comments, thoughts? Cool. Moving on then.
I have this segment. Let me pull it up. So guess the stat. I have five. I was just gonna pick one, but if you guys want to do all, we can. Let's not take our time guessing.
10 seconds. 10 seconds. How about that? 10 seconds.
Let me show you the first slide so you know how it works.
Okay.
Basically, it's guess the stat. All right. There's a bunch of stats about the healthcare system, pricing, all that. And you just guess the blank. And then I have the answers in the next slide. There's about like 3 to 5. The last one has 7, but you'll see. Okay.
Okay.
Next. And this is our friend Susie. She's gonna be helping us throughout.
Hey, Susie
Okay.
girl.
Hi, yes,
She doesn't like you. Okay.
Did she like me?
Next. No. So high cost.
Who?
Blank T. Marie. So high cost. Blank prescriptions filled in 2024. Blank total out of pocket spent in 2024. Blank average spent per prescription in 2024, which was a blank increase since 2023. And then a blank percent in price change since 2014. I feel like
is there multiple choice to this? Because I have no idea.
okay, this is
You
what
just
I'll do.
guess?
I was just gonna let y'all guess. Like how many prescriptions do you think were filled in 2024? And I'll write your answers down and read it back.
Okay. 10 billion.
Yeah, I was thinking the billion.
10 billion prescriptions filled in 2024.
This is
Yeah.
the US?
Yeah.
Yeah.
Oh,
Okay.
no.
Okay.
There could be. Hold up.
A billion.
1 billion?
1 billion. 200 million? I don't know.
Okay. Pick a number. Do y'all agree with 10 billion, 1 billion, 200
5
million,
billion.
5 billion?
5 billion.
600 million. I go with 600 million.
Okay, so you said 5 billion, 600 million. All right. So, blank total out of pocket spent. So, how much money was spent out of pocket in 2024?
10 billion. No, 100 billion. No, I
$100
don't know.
billion dollars?
Yeah, $100 billion. I don't know. Just, I feel stupid with it.
I'm going to say 50 billion. No. 25 billion.
25. Okay. T, you said 25. Shreya, you said 100.
Mm.
Average money spent per prescription in 2024.
$500? No, $500.
500 per prescription. Okay.
Maybe 300?
325.
125, you said?
325
Okay.
dollars.
325.
I think that sounds about right, actually.
And wait, what did you say? You said 500?
Yeah, I was thinking around 500, yeah.
Per prescription. Okay. And then what is that increase since 2023? What percentage increase was that?
15%.
Have you looked this stuff up? Or are you just
No,
guessing?
girl, you know I'm just saying numbers.
8%.
Okay, 8%. And then percentage price change since 2014. So 10 years.
25.
50 and 25?
Yeah.
I was actually thinking around 150, but 50 sounds about right. Let's go with 50.
All right, ready for these numbers?
Yeah.
Oh my God.
You don't have to remind us what we said.
Yeah, I got you. Oh, I'm on the wrong slide. Susie, you guys said for prescriptions filled in 2014, T said 5 billion, Shreya said 600 million. There was 4.2 billion prescriptions filled in 2014.
I win! I'm joking, I'm sorry.
For the total out of pocket spent in 2014, he said 25 billion, Shreya said 100 billion. It was 61 billion. For the average spent per prescription in 2014, T said $325, Shreya said $500. It's $14.57.
I wonder what this prescription is for.
Per prescription, like overall. So it's including the ones that are like 500 out of pocket, but also the ones that are like $3 out of pocket. You know, so it's like average. Yeah.
I was valuing the higher
This is not bad.
price ones more.
$14 is not bad.
So then the percent increase since 2013 is a 4.3% increase. T said 15%, Shreya said 8%. And then price change since 2014, which is crazy. There has been a 37% increase in the price change for prescriptions in 1 decade. T, you said 25%, Shreya, you said 50%. So like in the middle.
Wow.
Not bad. Not bad at all.
Thoughts, comments, concerns, anything, any statistic that stands out?
The average is interesting. I would like to see the median and the markers to understand what is it called when you know the percentile. I would like to see the percentile division of this to understand where it stands.
I agree. I think a lot of these, I got it from GoodRx. I don't know if you guys know GoodRx, but GoodRx is like, I'm Mark Cuban helped create it, but if you don't have like proper health insurance or coverage, you can go to GoodRx to get coupons for certain things. But yeah, they give us all of these statistics come from their website. Crazy. Moving forward. Okay, next, Medicaid or Medicare coverage. So blank percent of drugs are covered by Medicare.
I understand the question. Does it mean like what exactly is it trying to ask?
70%.
Blank percent of drugs are covered by Medicare. 70?
Yeah.
I would go with like 98.
Okay. Blank percent of drugs with Medicare have restrictions. So you can get the drug if you fit a certain eligibility.
45.
50.
Okay. And lastly, blank percent of Americans with Medicare, or blank percent of Americans have Medicare and uncovered RX. So like an uncovered prescription. So they have the Medicare, but the prescription they need isn't covered by it.
60.
60.
I don't even think 60% of Americans have Medicare.
Oh, wait, hold up. Yeah, because these are
No, it says of
paid
people with
Of people with coverage, you're
with.
saying?
Americans with Medicare
Okay.
who have a prescription, but it's not covered by the Medicare.
Oh, okay. Yeah, 60.
20, 30, 30, 20,
20.
20.
Oh, girl, I'm writing with a pen.
Dangling in between. Dangling in between.
20 to 30.
25.
No, 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 20 is
What's the
fine.
answer? 20? Okay.
Susie, tell me the answers. Sorry, sorry.
See, it's Susie is going to tell you the answers. So, 56% of
Yeah! Okay, never
drugs
mind.
are, congratulations, I'll get you a cookie. 56% of drugs are covered by Medicare. T, you said 70. Shreya, you said 98.
I was wrong. Very wrong.
Yeah,
Um,
you were cheering. I was like, I thought I won. Okay.
I had no idea.
49% of drugs are covered with Medicare with restrictions. T, you said 45. Shreya, you said 50, so close. And then 20% of Americans who have Medicare have a prescription that isn't covered. So T, you said 60. Shreya, you said 20. Right on it.
Right on the money.
Thoughts, comments, questions, concerns?
I'm a genius. I should become a psychic.
Definitely talking about the healthcare. But yeah, you be a genius with 98% drugs covered by Medicare.
You have to point out the one that I didn't get right. Shut up.
If you're gonna call yourself a genius, like,
No, but this is really
Geniuses can be
interesting.
wrong. They don't get everything right.
fair. Yeah. I did think it was so crazy that 49%, first off, that it's only 56% of drugs that are covered, right?
Mm-hmm.
So, like, the other, 44%? Is it 44?
Yeah. Yeah, 44.
Yeah, 44% of drugs, like, that people need but isn't covered by Medicare. So you have to do out of pocket. And then on top of that, the drugs that are covered by Medicare have restrictions. That's 49%. So there's only, let me do math, 7% that aren't restricted that you can just get with Medicare. Crazy. No comment. Moving forward, or thoughts, comments, questions, concerns?
This is fun.
Okay. Part 3, commercial insurance coverage. So this is like the privatized insurance. Blank percent of drugs covered by commercial insurance.
98.
Yeah, I'm going to assume it's high. I was going to say 80, 85. Put 85.
85 and 98. Okay.
I'm
Blank
very
percent of drugs. Very optimistic. Fair. Blank percent of drugs that are covered but have restrictions.
100%.
Okay.
No, that can't be my real answer. 90. 90.
75.
90. And then lastly, blank percent of Americans that have commercial insurance, but the prescription they need isn't covered.
15%? 20%? I don't know.
40.
40.
Okay. Susie, what's the answer?
Fuji.
So 79% of drugs are covered by commercial insurance. T, you said 85. Shreya, you said 98.
No, I said 90.
Okay, 90.
Oh no, the next one was 90. My bad, my bad, my bad. You were right. You were right.
Let's take a breather. Let's just take a deep breath, okay? It's a game for fun.
No, I know, which is why I'm having fun. It's just me excited.
Yeah. Okay. 35% of drugs have a restriction with commercial insurance.
I'm very
T, you
surprised.
said 70. T, you said 75. Shreya, you said 90. And then 23% of Americans with commercial insurance have an uncovered prescription. T, you said 40. Shreya, you said 15. Thoughts, comments, questions, concerns, standouts?
I am really surprised with the lack of commercial restrictions. But when you think about it, 35% is not that low. It's just not as high as I expected it to be.
Fair. I'm more surprised by like the difference between this and not difference, but Medicaid
Yeah.
or Medicare, because like there's 20% of Americans with Medicare, but they can't cover a prescription. It only increases 3% with commercial insurance, right? And hold on, let me go back. Like 56% of drugs are covered by Medicare, 79%. That's a fairly big increase, but 49% with restrictions on Medicare, with only 35% with restrictions on commercial. Okay.
Mm-hmm.
Increased friction.
What?
What does that mean?
Increased friction. So, like, you'll see. Blank percent of Americans lack pharmacy access.
That's a weird one. Okay. Mm. What do you mean by lack pharmacy access? Is it like in their block? What are we talking about?
They lack access to a pharmacy, whatever reason they have. My bad.
Dang, how many Americans are there? I'm
10,
gonna
20 million?
say
10 million.
10 million.
I'll say
Okay.
15. Because I'm really thinking about the rural states, but yeah, I'll say 15.
All right. So blank number of Americans are leaving their prescription at a pharmacy monthly. So they basically can't get the prescription. So they're just like, okay, here. They're leaving without it. Monthly,
10
monthly,
million.
not yearly.
500,000.
500,000.
35. Three for
Thousand.
how what is America's population?
I don't know.
How do you not know? Okay, so you have a population of 340 million, and I'll say 150 million leave their prescriptions at the pharmacy.
And then blank percent who opted out due to restrictions. So they opted out of getting their prescribed medication because there was too many restrictions on it that they
100
couldn't get.
million.
It's a percentage.
10.
15%.
All right. So 48 million Americans lack pharmacy access. T, you
That-
said 15 million. Shreya, you said 10 million. 46 million Americans leave their prescription at the pharmacy a month. So T, you said 500,000. Shreya, you said 150 million. That's actually crazy, like realizing it's 46 million a month.
Yeah.
31% of people opted out of their prescription due to the restrictions placed on them. 10% is what you said, T, and 15% is what you said.
Wow.
Wow. We were off.
That's concerning.
Very. 46 million people a month in America leave their farm or leave their prescription because they can't
And the
get it.
fact that so many don't even have access to a
Mm-hmm.
pharmacy. And I'm just thinking around here, there's so many different ones I could go to, and they just, wow,
Crazy.
it's crazy.
And then 31% of Americans who are just like, yeah, don't give me the prescription. Like the restrictions aren't fitting. Well, they're not choosing not to get the prescription. The restrictions aren't allowing them to get the prescription.
Mm-hmm.
So, so sad.
What do they want them to do?
Um,
I don't understand.
what I'm saying, it's weaponized. Last part. This has to deal with the price of drugs. Okay?
Okay, let's
So
go.
these are common diseases or conditions that people have um in America and the cost for a prescription, like an average prescription for this. So fertility, hepatitis C, erectile dysfunction, type 2 diabetes, Crohn's disease, and then weight loss. How much would you say is the cost of one of these, of a prescription for it? And then what percent increase or decrease is that? Oh, I missed some positives or negatives on there. It's fine. Let me see. You can start guessing. With fertility, how much do you think it costs and what's the increase?
I know that's expensive from like different people's experience I've heard.
Depends on
The
what kind.
ones with, sorry, the ones without a positive sign in front is a decrease
Can you
in the
explain the
cost.
increase? Oh, with the Oh, okay.
Yeah,
Increase or decrease in
sorry,
price
of the cost. Yeah, so
of the
it's
cost.
how much does it cost as of 2024, and then what was that increase or decrease from the year prior? I think the year prior.
Ah,
Let me double check.
Yeah, but when you say
I think
fertility, what do you mean? You're talking about women's, men? Are
like
we
out of
talking
pocket
about?
cost for these drugs.
Yes, but what kind of fertility drug are we talking about? Are we talking about ovulation, something that speeds up
The
ovulation?
average, the average fertility medicine. Average, if you have medicine for fertility, the average out of pocket cost,
I'm gonna
whether it's
say
man, female.
1,500 for out of pocket. And then I would say that's maybe like a 5% increase from the prior year.
And we're talking only out of pocket.
Mm-hmm.
But fertility is not usually covered under insurance. Most insurances don't cover fertility. So the average would be pretty high. $3,000, I'm guessing. I think it would be closer to $1,300, $13,000. but if they have insurance, then 3,000. And a 20% increase,
All right, hepatitis C.
$500.
I have no baseline for this one. This feels okay. It's a STD, correct?
No.
I'll cut that out.
Hepatitis A, B, and C. I don't. It has to do with your liver. I know that for sure, and it's hard to cure
I'm
for me.
embarrassed. Okay. Let's see. I'm just gonna restart what I said. I have no basis for this one. I'll say 2000, and let's just say it's a 10% increase from the prior year.
This is a decrease. The ones without plus signs.
I'm gonna say it's a 10%, 5% decrease from the prior year.
Let me make sure it's decreased by the year and not the month or not the decade. Sorry, one second. Let me go back to the source.
Wasn't one of the hepatitis?
What did I say for hepatitis C?
You said 500.
No, make that 10,000.
Okay, so this is what 10,000.
Yeah.
Yeah, they said B and C are viral infections and are sexually transmitted diseases.
Oh, so you're right. Never have I ever heard that hepatitis is a sex trans
Just from
or
blood
STD.
transfusions. I thought it was just from blood transfusions and shared needles. Hepatitis
They
C.
did say
That's
it
shared needles,
primarily
yeah.
affects the liver.
hmm Um, it says that this is costly conditions like American with certain health conditions often face higher than average out-of-pocket costs. These disparities can stem from inadequate insurance coverage, high prices for specific medication, or the absence of affordable generic alternatives. So it's just the average prescription for the thing. And it says since 2024, there's been a blank percent increase and a blank percent decrease. I don't understand what that means. From where?
Um, okay. So can we rethink our answers then?
I mean, it's the same thing you've been guessing also. It's just the average cost.
Okay,
But
fertility,
it's
I think it's 30,000, not 13. And hepatitis C, I'm going to go with an average of 10,000. With a 10% increase and a 25% increase.
What did I say?
hold on. You said 1500 for fertility and then that it was a 5% increase and then you said
Mm-hmm.
200 for hepatitis C and that it was a 5% decrease.
Yeah, I'm gonna change. I'll keep the decrease because I really don't know, but I'm gonna change the price to 2000 because that
For
sounds like
hepatitis?
that sounds like a nice number.
Okay. So next is erectile dysfunction. Hold on.
Bless you.
Thank you. Next is erectile dysfunction. How much out of pocket per prescription is being paid on average, and what is that increase since 2024?
At first, I was thinking, is this something like Viagra? But Viagra is like over the counter, so that's like different, right? That's not prescription.
Viagra can be prescribed too.
What can?
hmm
In my mind, I feel like that's not that expensive, but I know there's probably other ones that are more expensive and are more,
hmm
tailored to.
It's
Hmm.
like anything that has to do with erectile dysfunction, the average cost per prescription.
Okay.
I know it's a general statement, but that's how they took all of the
$15?
information, just made it general. 15.
I'm guessing because it's fairly common.
And then the increase. Let's take not too long to think, ladies.
Increase of 20%. Make it $20 and 20%.
I'm gonna say 100 just because I'm not sure if there's more expensive medications than Viagra. And I'll say it's like a 4% increase.
Okay. Type 2 diabetes, what is the average cost per prescription out of pocket, and what is that decrease?
I'm gonna say $150, $50, $150, $50, $50, $50, $150, $50. Pick one. I think it's a decrease of around 20%.
I am going to say I'm gonna say $70, and I'm gonna say it is a decrease of 15%.
Okay. Crohn's disease, how much does it cost on average out of pocket per prescription? And then what is the percentage decrease from 2024?
I have no idea what Crohn's disease is, so I have
Yeah,
no
I'm
idea.
not familiar, so I'm just gonna guess. I'm gonna say $200, and let's just say it's a decrease of 10%.
Okay. I'll say 100 and a decrease of 10%.
Okay, lastly, weight loss. What is the average cost per prescription out of pocket? And what increase or decrease in percentage is that from 2024?
I'm gonna say 2,500, and I'll say it is a 3% decrease.
I will say it's $280 and a decrease of 50%.
Okay,
I think we're going to be
these
so
numbers
off.
might. Shreya, are you cheating?
What? No, why?
Okay, I'm just
Because you're
asking.
good. That's what that
No,
means. It
no,
means
not
you're
because
good.
she's good. I think this number will surprise you. It's because I heard click clacking and your eyes moving, and I was like, let's see. The numbers are. They're probably going to surprise you. They kind of surprised me. So for fertility, the average out-of-pocket cost is $330.31, which is a 13.3% increase since 2024. Really high increase, but it's still the average out-of-pocket cost did surprise me that it was that low.
Hmm.
T, you said 1,500 with a 5% increase. Trey, you said 30,000 with a 10% increase. Or yeah, with a
Would I
10%
be
increase.
cheating with numbers like this? Please tell me.
I was just asking. I didn't
No,
know
I
the
know.
answer.
I know.
Yeah. Okay. Next, with hepatitis C, it is $582.69 out of pocket on average per prescription, which is a 12.5% decrease since 2024. I still don't understand the increase and decrease because all it said on the website is since 2024 and it's 2025. Anyway, uh, T, you said 2,000, Shreya, you said 10,000.
Then you
Um,
said they were unaffordable, so I thought it would be this much.
that's fair. A 10% decrease. No, T, you said 5% decrease. Shreya, you said 25% decrease. For erectile dysfunction, it is $106.38 out of pocket cost per prescription on average, with a 2.9% increase since 2024. T, you said $100. Shreya, you said $25. T, you said 4%. Shreya, you said 20%. And then type 2 diabetes is on average out of pocket cost, which I think is going back to what Shreya said about the ceiling cost for insulin. So it's
Oh.
$20.33 on average out of pocket per prescription, which is a 4.1% decrease since 2024. T, you said $70 with a 15% decrease. Shreya, you said $50 with a 20% decrease. For Crohn's disease, which I actually still don't know what that is, it's $118.05 for the cost per prescription out of pocket on average, with a 4.3% decrease. T, you said $200 with a 10% decrease. Shreya, you said $100 with a 10% decrease. And then weight loss on average is $85.38 with a 12.1% decrease in cost since 2024. Shreya, you said, or T, you said 2,500 with a 3% decrease, and Shreya, you said $280 with a 50.
I'm actually surprised
Wow.
about the type 2 diabetes because the one I was talking about, the drug controlled one, the price controlled one, was insulin, and that's not usually prescribed for type 2. It's type 1.
Sure, true.
Hmm.
My dad has a lot of meds for type 2. These all kind of surprise me, but it's not. First, it's on average. Second, it's per prescription. And third, it's out of pocket cost.
Yeah.
So for some people, their insurance might cover more than others, so it changes the average. But
Mm-hmm.
still, if you think about it, if on average, the average person is paying $330.31 per prescription and say they have to get that refilled once a month, that's like a car payment.
Yeah.
Like that's a car payment. Hepatitis C, like it's a whole other bill to pay just for your wellness when your society should be helping you with your wellness. Um, and this is out of pocket cost. So it probably costs more, but
Yeah.
certain insurances negotiate it down. So yeah. Thoughts, comments, questions, concerns, surprises?
No, it's just, it sounds like a lot.
It's very interesting.
Insert something, insert something.
Lovely, lovely, lovely segment. Is there more?
Mm-hmm.
Nope, that's the last one.
Great job.
Great job, yeah.
Mercy, mercy, mercy.
Okay, so that was such a great conversation. I think we were able to cover a lot of topics that are so timely in both countries that we are currently living in out of our three members and everything. And I think this is something that should be discussed more. I think there's so much that we can learn. And even though, as Rose mentioned, we kind of have our own talents where maybe it's not within the healthcare field, but we feel the need to want to like fix it and do something to aid it. But I think just having these conversations, I think it makes it maybe a little bit more approachable for people like us who aren't as well versed in it and only know what we know. So yeah, let's absolutely continue conversations like this. Drop your thoughts down in the comments below, and until next time,
Stay curious.
stay true.
And stay unapologetically you. Bye.
Bye.